You've probably heard of tuberculosis, right? It's a disease that's been around forever, since the time of the pyramids. And yet, it is still one of the world's deadliest infectious killers. So, what's its secret? How is it so persistent? Well, it all comes down to this incredible ability it has to just go to sleep right inside the human body.
Just imagine this. A bacteria gets into your lungs, but instead of making you sick right away, it just goes to sleep. And it can stay there, totally dormant for decades, your whole life even, like a silent passenger. This isn't some sci-fi movie plot. This is the reality for almost a quarter of all the people on Earth.
So, how does your body deal with this invasion? Well, it does something pretty amazing, actually. Your immune system literally builds a wall. It creates this tiny fortress of immune cells, and we call that a granuloma. Just think of it like a biological prison, okay? It's perfectly designed to surround and contain the TB bacteria, essentially putting them on lockdown. And that whole prison idea, that's the key to understanding the two faces of tuberculosis. See, it's not just one thing. There are two completely different states of being for this infection. You've got the sleeping prisoner, and then you have the escaped convict. Let's break down what that really means. Okay, so this is the crucial distinction. On one side, you have latent TB. The bacteria is asleep. You feel totally fine, you have zero symptoms, and this is key, you absolutely cannot spread it to anyone. Your chest x-ray looks completely normal. But then you have active TB. This is when the giant awakens. Now the bacteria are multiplying like crazy, you feel sick, you are contagious, and your x-ray is going to show the battle that's raging inside your lungs. So what makes the giant wake up? What breaks down those prison walls? Well, basically, it's anything that weakens your immune system. We're talking about things like an HIV infection or being on immunosuppressant drugs after an organ transplant, even long-term steroid use or some of these newer biologic drugs like infliximab. They can all weaken the guards, so to speak, and that gives the dormant bacteria the perfect chance to break out and reactivate. So when the giant does awaken, how do we even know? How do doctors catch it? Well, the whole process really starts by recognizing a very classic set of warning signs.
Yeah, you could almost call these the four horsemen of active TB. First, a cough that just will not go away. Then, fevers that keep coming back. Drenching night sweats, and I mean you're soaking the sheets. And finally, losing weight when you're not even trying. These are what we call constitutional symptoms, and they are a huge red flag that something serious is going on. So if a doctor suspects TB based on those symptoms, the very next step is to get a chest x-ray to literally look inside the lungs. And they're looking for signs just like this. See that cloudy, patchy area? That's called an infiltrate, a classic sign of active TB. Sometimes they even find what are called cavities, which are basically holes that the infection has eaten into the lung tissue. Okay, so once that x-ray comes back looking suspicious, things start to move really fast. First things first, because active TB spreads through the air, the patient has to be put in what's called airborne isolation. That's to protect everyone else. Then comes the crucial step, collecting sputum samples. Usually, it's first thing in the morning for 3 days straight. Those samples go to the lab where they use a special stain to look for the bacteria themselves. And that's how you confirm the diagnosis. Now, the good news is we have incredibly effective drugs to fight TB. The bad news? This bacteria is one tough customer. You can't just throw one antibiotic at it. Nope, you need a powerful 4-drug cocktail. And thankfully, there's a great mnemonic to remember them, RIPE. So each drug in this RIPE regimen has its own job, but also its own key side effect to watch out for. R is for rifampin, and it famously turns your body fluids, like urine and tears, a harmless reddish-orange. I is for isoniazid, which can cause nerve damage, and that's why patients also take vitamin B6 to prevent that. P is for pyrazinamide, which can spike your uric acid levels. And finally, E is for ethambutol. Think E for eyes. It can cause vision problems, so regular eye checks are an absolute must. Now, as clever as that RIPE mnemonic is, there's another, kind of darker one that doctors use. It's to remember a really serious side effect that 3 of those 4 drugs share. Rifampin, isoniazid, and pyrazinamide, they can all be toxic to the liver. So the mnemonic is rest in peace, liver. It's a pretty stark reminder that you have to monitor liver function very, very closely during treatment. Yeah, treating TB is definitely a marathon, not a sprint. The standard treatment for an uncomplicated active case is a full 6 months. It starts with a really intense 2-month phase where you're taking all 4 ripe drugs. The goal there is to kill off as much of the bacteria as you can, as quickly as you can. After that, you drop down to just 2 drugs, rifampin and isoniazid, for the final 4 months. That's the cleanup crew, making sure to wipe out any stubborn survivors. Okay, so we know how to find and treat active TB, but what about the billions of people walking around with a sleeping latent infection? I mean, that's the real public health challenge, right? Finding them before the giant ever gets a chance to wake up. For this, we basically have 2 main tools in our toolbox. There's the old school PPD skin test, and then there's the more modern IGRA blood test. Now, the blood test has one huge advantage. It isn't affected by something called the BCG vaccine. That's a TB vaccine that's common in many parts of the world, and it can actually cause a false positive on the skin test. So the blood test is much more reliable for people who've had that vaccine. All right, so let's say you get one of these screening tests done, and it comes back positive. It means your immune system has seen TB before. So what's the single most important #1 thing you need to do next? What's the immediate question we have to answer? This, right here. This is the absolute crucial point. A positive screen just tells you that you've been exposed at some point in your life. It doesn't tell you if the infection is sleeping or if it's awake and active. So the very first step every single time is to get a chest x-ray to see if that giant is awake and causing problems right now. But here's a really important detail, especially about the old skin test. What we consider positive isn't just one number. It's not a one-size-fits-all thing. The size of the bump on your arm that counts as positive, it depends entirely on how high your personal risk is. So for the highest risk people, we're talking about someone with HIV, or an organ transplant recipient, or somebody who lives with a person who has active TB. The bar is set really low. Even a small reaction, just 5 millimeters, is considered positive for them. Now let's go to the next level, the intermediate risk group. This is where people like healthcare workers, recent immigrants from high TB countries, or IV drug users fall. For them, the threshold goes up. It takes a reaction of 10 millimeters or more to be called positive. And finally, we have everybody else, the general population, people with no known risk factors for TB. For this group, the bar is the highest. For it to be a positive result, the reaction needs to be 15 millimeters or bigger. Okay, so let's put this to the test with a quick case study. Imagine a perfectly healthy healthcare worker. They get their routine PPD test, and the result is a little bump, an induration, that measures 12 millimeters. So, based on the rules we just went over, is that a positive test? What do you think? Yes, absolutely. It is positive. Why? Because as a healthcare worker, they fall into that intermediate risk group, where the cutoff is 10 millimeters. And since 12 is bigger than 10, it's a positive screen. So, what's the very next step? You got it. Get a chest x-ray to rule out active disease. And that really brings us to the final massive question, doesn't it? We know how to diagnose it. We know how to treat it when it's active. We even know how to screen for the silent version. But when you're talking about an infection that's hiding inside nearly a quarter of the entire world's population, the real challenge is this: how in the world do we stop that sleeping giant from ever waking up in the first place?